My name is Nick Brodnicki, and I'm the Executive Director at the American Heart Association in Oregon and Southwest Washington. Today, we're joining forces with Hillsboro Medical Center to reduce cardiovascular death, heart attack, stroke, and heart failure in our communities. Now, a couple of housekeeping items before we begin. Today's discussion is a webinar format, and even though we can't see you, we want to hear from you. We will have time at the end for audience Q&A, so please put your questions in the chat box. And as you've probably heard for a couple of years now, make sure to choose all panelists and attendees from the dropdown. Now, because this is a healthcare education opportunity, we do have a disclaimer that I'm going to read for you before we jump in. This presentation and related materials do not constitute the practice of medical advice, treatment, or diagnosis. Always talk to your healthcare provider for diagnosis and treatment, including your specific medical needs. If you have or suspect that you have a medical problem or condition, please contact a qualified healthcare professional immediately. If you are in the United States and experiencing a medical emergency, call 911 or call for emergency medical help immediately. So, with that said, thank you, everybody. It is now my pleasure to introduce Dr. Nandita Gupta, Associate Chief Medical Officer at Hillsboro Medical Center. Prior to holding this role, she was the Medical Director of Cardiovascular Services at HMC for 3 years. Dr. Gupta's community service leadership also includes her service as the American Heart Association's board president for our region. And I need to mention, Dr. Gupta's commitment to heart health has seen her voted as a top doctor in Portland Monthly Magazine for the past 4 years. Welcome to the conversation, Dr. Gupta.
Thank you, Nick, for that kind introduction, and welcome everyone. Good afternoon. Thank you for joining us today on this maternal health webinar. Today's discussion will center around collaborative maternal health care throughout the stages of pregnancy. Now, each part of a women's care team plays a different but equally important role. We hope you'll come away from this presentation today with a greater understanding of why and how decisions are made for the benefit of both the mother and the child. Let me start off by thanking our friends at the American Heart Association who work tirelessly to improve the heart and brain health for everyone, particularly the Executive Director, Nick Brodnicki, who you just heard from. Next, I'd like to thank my team at Hillsboro Medical Center and our speakers for today's event. This group works daily to improve the lives of women and mothers through meticulous care. I'll kick off by introducing our experts. Dr. Shara Sipperstein specializes in obstetrics and gynecology at OHSU Hillsboro Medical Center. She enjoys building relationships with her patients and providing patient-centered care. As a generalist, she sees both low and high-risk OB patients and has a particular interest in substance use disorders in pregnancy. We also have with us Dr. Alicia Jackson. She's a board-certified family medicine physician. She's the medical director of the OHSU Health Primary Care Clinic in South Hillsboro and the associate program director for the OHSU Hillsboro Medical Center Family Medicine Residency Program. Her clinical interests include full-spectrum family medicine, including inpatient care, maternity care, pediatrics, and global health. She's passionate and committed to efforts focusing on expanding diversity in our healthcare workforce, health equity, and social justice. She enjoys participating in advocacy and local events within the community for the underserved population, especially mentoring our underprivileged minority youth. We also have on our panel Vinay Yuki. Vinay is a board-certified nurse midwife. She has certified in trauma-informed care principles, team steps collaboration, and advanced life support in obstetrics. She's in the final year of completing her doctoral studies focusing on perinatal safety. She integrates wellness, personal experiences, health promotion, and years of collaborative practice, which she feels is particularly well-matched to serve patients with low and high-risk pregnancy. She's interested in integrating the trauma-informed framework into patient care delivery, community-focused health initiatives, and educational program. With this expert panel as a background for our topic of discussion today, let me highlight to you that the United States has the highest maternal mortality rate of any nation studied, at nearly 24 deaths per 100,000 live births. Women in the US face the highest rate of prevalence of maternal and preventable mortality when compared to women in 10 other wealthy nations. And this number has been on the rise for the past several years. Hypertensive disorders of pregnancy are one of the leading contributors to maternal and fetal morbidity and mortality. They're the second leading cause of death during pregnancy, and hypertension is the leading cause of postpartum readmissions in the United States. As such, pregnancy provides a window into the future cardiovascular risk and an opportunity for early intervention to treat cardiovascular risk factors at a younger age and reduce this risk. One of these early risk factors is hypertensive disorders of pregnancy. So in today's webinar, we will learn from our expert panelists. First, Vinay will share background information on preeclampsia and share a case study. Then Dr. Sepperstein will outline some definitions and management of hypertensive disorders in pregnancy. And lastly, Dr. Jackson will wrap up the conversation with bringing us back to the case study and also highlighting aspects of postpartum care. So I'm going to hand over to Vinay first. Thank you again so much for joining us for this important conversation.
Thank you, Dr. Gupta. I think we need to put in the context the impact that preeclampsia has and why it's so important. It occurs in 5 to 7% of pregnancies, and it actually impacts about 10 million pregnancies a year worldwide. Hypertensive disorders are responsible for 14% of maternal deaths worldwide and 7.8% of maternal deaths in the United States. If a person has preeclampsia, it's associated with a 4.5-fold increased risk for maternal death. There's several risk factors for preeclampsia. Some of them include multifetal gestation, prior history of preeclampsia, chronic hypertension, an inflammatory process such as pregestational diabetes, sleep apnea, maternal age, and BMI. When we think about the pathophysiology of preeclampsia, we need to think about the placental dysfunction and the stress that results from the placental malperfusion. There's some overlying themes, including the abnormal placentation, cellular aging, placental ischemia that's caused by the impaired placental spiral artery remodeling. The mechanism reflects the ischemia, followed by the release of anti-angiogenic and pro-inflammatory placental factors, the upregulation of the endothelium system, resulting in impaired production of nitric oxide, vasoconstriction, and then some functional disruptions. The disease phenotype actually depends on multiple factors. In our case study, we're going to be talking today about Casey. She's a 24-year-old female who's pregnant with her first baby. Her family history is non-contributory. She's an only child of an only child, and her mom's pregnancy went just fine. She's also very physically active, and she doesn't eat a lot of processed foods, and she considers herself to be very muscular. She attends CrossFit exercise at least 3 times a week, and in between, she lifts weights. At her first prenatal visit, she's 5'4", and her weight is noted to be 195, which puts her BMI at 34. Her vital signs were normal, good pulse, good respirations, but her blood pressure was 139/89. She reports being very nervous, and on recheck, her blood pressure was 120/80. At that visit, she was counseled about limiting her gestational weight gain because of her current BMI, and she was also counseled about exercise during pregnancy. By 32 weeks, Casey has already gained 30 pounds and reports continuing to be stressed because she's in graduate school. At this visit, she actually sees a new midwife provider, and she also tells that provider that she's in a rush to her appointment. She shows up out of breath, and her blood pressure is 140/89. They repeat it, and it's 139/91. She becomes a little bit argumentative with the medical assistant because the blood pressure was elevated, and she reports continuing to be nervous. Despite Casey's nervousness, the provider sends her from the clinic to labor and delivery for serial blood pressure monitoring and lab work to evaluate her for preeclampsia. Casey reports that she's really uneasy because she doesn't believe the blood pressure is reliable because her blood pressure has never been that high. So when Casey's at the triage, her initial blood pressures were elevated, but as she becomes more relaxed and comfortable, her blood pressure actually normalizes. The provider at labor and delivery tells her that her blood work is reassuring. So Casey begins to question her blood pressure elevations, and she says, is my pressure elevated because I'm nervous and stressed out? Casey is told that she has gestational hypertension, and she's sent home from the labor and delivery in stable condition. She was given warning signs and instructions to monitor her blood pressure at home. She was not sent home with a blood pressure cuff because her insurance company requires the prescription to be sent to a specific company for DME processing and be sent to her in the mail. Casey actually missed her next appointment, and she's not seen again in the clinic until she's 35 weeks pregnant. And at this visit, her blood pressure is significantly elevated, and she is immediately sent to labor and delivery for evaluation. Casey was subsequently admitted for observation and blood pressure management. She was given IV medications to stabilize her blood pressure. She was given steroids to mature her baby's lungs just in case she delivers early. She was then advised that she has a new diagnosis of preeclampsia. Casey's blood pressure responds to the medications, and she was continued to be observed for 24 hours while her obstetrics team collaborated to develop a delivery plan. So while she was hospitalized, Casey decides to do some research about gestational hypertension and preeclampsia. I'd like to transition to Dr. Saperstein, who's going to continue to outline definitions and management of hypertensive conditions of pregnancy.
Good afternoon, everyone. I'd like to start off by reviewing some definitions of hypertension and pregnancy. It's important to note that there's a lack of global consensus regarding these definitions, but for today, I will proceed with reviewing the definitions by American College of Obstetrics and Gynecology and their recommendations. Gestational hypertension is defined as blood pressures on two equations greater than 4 hours apart that are greater than 140/90 that occur at greater than 20 weeks gestation in women who had previously normal blood pressures. Preeclampsia is defined as a disorder of pregnancy with new onset hypertension greater than 140/90 accompanied by new onset proteinuria. Proteinuria in preeclampsia is a result of increased renal tubular permeability and is defined as greater than 300 milligrams per deciliter of protein in a 24-hour urine collection. It is also commonly measured using a spot protein to creatinine ratio of greater than 0.3. Up to 50% of women with gestational hypertension will develop proteinuria or other end organ damage consistent with a diagnosis of preeclampsia. Preeclampsia can be further stratified into preeclampsia without severe features and preeclampsia with severe features. A patient has preeclampsia with severe features if any of the following severe features are present. Severe sustained blood pressures greater than 160 systolic or greater than 110 diastolic. Thrombocytopenia resulting from increased platelet activation, aggregation, and consumption. Renal insufficiency measured by serum creatinine levels as a result of renal vasospasm and decreased filtration. Liver dysfunction related to periportal necrosis and leakage of liver enzymes into the bloodstream. Pulmonary edema or other neurologic symptoms such as headache that's unresponsive to medication, visual symptoms such as blurred vision or scotomata. Severe blood pressures or severe features increase the risk of maternal morbidity and mortality associated with preeclampsia. An even more severe form of preeclampsia is called HELP. Hemolysis, elevated liver enzymes, and low platelet count can also be associated with morbidity and mortality. This is defined by elevated LDH, elevated liver function tests, and low platelets. HELP may present with or without proteinuria. Eclampsia is a convulsive manifestation of hypertensive disorders of pregnancy and is a significant cause of maternal death. An eclamptic seizure may lead to maternal hypoxia, trauma, or aspiration pneumonia. 30% of women may not have classic signs of preeclampsia prior to a seizure episode. However, a seizure may be preceded by signs of cerebral irritation, such as severe headache, blurred vision, photophobia, or altered mental status due to elevated cerebral perfusion pressure and cerebral edema. As I previously mentioned, hypertensive disorders of pregnancy, specifically preeclampsia with severe features, increases the rates of maternal morbidity and mortality. When evaluating and treating a patient, we must keep in mind those maternal and fetal complications. Maternal complications include myocardial infarction, stroke, respiratory distress syndrome and pulmonary edema, coagulopathy, severe renal failure, retinal injury, eclampsia, and even subcapsular liver hematomas. Fetal complications are a result of exposure to that chronic uteroplacental insufficiency, resulting in possible fetal growth restriction, oligohydramnios, or non-reassuring fetal status. It can also be from the associations of preterm birth and its associated morbidity, even stillbirth or placental abruption. So now that we know our definitions, what do you do if you see a patient with high blood pressure in pregnancy? The two most important items are both maternal and fetal evaluations. Maternal evaluation includes the blood test listed, and fetal evaluations include fetal monitoring and measurement of the growth of the fetus. The next step is then to consider both maternal and fetal conditions in regards to delivery timing. This takes into account whether the diagnosis is early versus late gestation, with or without severe features, symptomatic or asymptomatic, and whether there's progressive or stable disease. I will next review the hallmark trials that have led to the current guidelines regarding delivery timing of a patient with hypertensive disorder of pregnancy. The HIPPOTAT trial is a randomized controlled trial evaluating maternal and neonatal complications in patients 36 to 41 weeks of gestation with gestational hypertension or preeclampsia without severe features who are randomized to either expectant management or induction of labor. Each arm had approximately 380 patients. The primary outcome looked at maternal morbidity, which included development of eclampsia, pulmonary edema, HELP, VTE, placental abruption, progression to severe hypertension, and postpartum hemorrhage. The results of this study showed lower rates of poor maternal outcomes in the induction of labor group versus expectant management with a relative risk of 0.71 without, and importantly, without an increase in neonatal complications. The conclusion of this study is the basis for our recommendation for patients with preeclampsia or gestational hypertension to be induced by 37 weeks of gestation. The clinical course of preeclampsia is characterized by a progressive deterioration of maternal and fetal condition. But what should we recommend between 34 and 37 weeks of gestation? The HIPPOTAT-2 trial emphasizes the interplay that both maternal and fetal health has in delivery timing. It is another randomized controlled trial looking at women between 34 to 37 weeks gestation with non-severe hypertensive disorders of pregnancy. There were approximately 350 patients randomized to each group, immediate delivery versus expectant management. Immediate delivery and non-severe preeclampsia between 34 and 37 weeks of gestation reduced the risk of adverse maternal outcomes only minimally. However, it significantly increased the risk of neonatal respiratory distress syndrome. So, we know that early delivery increases the risk of prematurity, while extending delivery may increase the risk of maternal complications. Our current recommendations are for expectant management of non-severe preeclampsia until 37 weeks and delivery of patients with preeclampsia with severe features at time of diagnosis if greater than 34 weeks of gestation. Important in these recommendations are for close maternal and fetal monitoring and continual reevaluation of both maternal and fetal status. But what if our patient is diagnosed with severe preeclampsia prior to 34 weeks of gestation? There are two hallmark randomized controlled trials looking at expectant management of severe preeclampsia versus immediate delivery in patients between 28 and 34 weeks of gestation. Results of these studies showed a more advanced gestational age at delivery, along with a reduction in neonatal complications and NICU admissions in the expectant management group. Maternal complication differences between each group, such as placental abruption and development of HELP, were non-significant. Several observational studies highlight maternal complications of expectant management, however. Therefore, in patients with preeclampsia with severe features, expectant management until 34 weeks is recommended, as this provides significant neonatal benefit, but may be at the expense of maternal risk. When evaluating a patient with preeclampsia with severe features, hospitalization is always indicated. There are two main goals of admission: prevention of seizures and acute control of hypertension, both to reduce the risk of maternal and fetal morbidity and mortality. The MAGPIE study is a randomized controlled trial of 10,000 participants showing that initiation of magnesium sulfate more than halved the rate of seizures in patients with preeclampsia with severe features. Alarmingly, the number needed to treat to prevent one seizure in a symptomatic preeclamptic patient is 36. Expeditious initiation of magnesium sulfate, either IV or IM, is important in the treatment of patients with severe preeclampsia. The main objectives to treat hypertension are to prevent congestive heart failure, myocardial infarction, renal injury or failure, ischemic or hemorrhagic stroke, and placental abruption. Safe hypertension and pregnancy bundles recommend expeditious management within 30 to 60 minutes of arrival, and severe range blood pressures can be treated with IV labetalol, IV hydralazine, or oral nifedipine. Once stable, to optimize fetal and maternal health, expectant management may be appropriate for preeclampsia with severe features to 34 weeks, or preeclampsia without severe features to 37 weeks by starting an oral agent. As previously mentioned, eclamptic seizures are convulsive manifestations of hypertensive disorders and can be new onset, tonic-clonic, focal, or multifocal seizures. In the absence of other causative conditions, magnesium sulfate is still superior to IV antiepileptics. This is the case even if convulsions recur and should be treated with additional IV magnesium boluses. Severe manifestations of preeclampsia, such as HELP, can rapidly progress. Monitoring labs at shorter intervals may heighten clinician awareness to these changes. Particularly important are knowing the trends. Expect platelet counts to be the lowest 24 hours after delivery, and reversal of this trend within 7 days. Preeclampsia and its spectrum of associated conditions comes with lifelong consequences. Women have higher rates of mental health conditions due to associated birth trauma. They also have a threefold increased risk of developing cardiovascular disease later in life. I will now hand off to Dr. Jackson to speak on those cardiovascular risks further.
Thank you so much, Dr. Zaberstein. So I wanted to focus my talk particularly on kind of defining the differences between hypertension in pregnant versus non-pregnant patients, as well as discuss the outpatient management of hypertensive disorders in pregnancy as well in the postpartum period. So what you can see here is showing you that in 2017, the American College of Cardiology and American Heart Association actually redefined what hypertension is in the non-pregnant patient, with the new definition being a blood pressure greater than or equal to 130/80. However, ACOG had actually looked at these guidelines in 2013, as well as in 2019 and 2020, and still decided to keep the hypertension definition in pregnant patients to be greater than or equal to 140/90. And so why is that? We'll explore some of the controversies related to this. So basically, there's been no global consensus yet in the OBGYN field regarding this. And that's due to lack of information about associations with postpartum outcomes. So some current trends that we see is that the incidence of hypertensive disorders in pregnancy are increasing. Some of those factors are related to older age at first pregnancy, as well as an increased prevalence of obesity and other cardiometabolic risk factors. As people mentioned before, up to 50% of all maternal deaths are related to cardiovascular disease, particularly stroke and cardiomyopathy. Some of the three main debated issues that have come up related to this lack of consensus is related to no measurable or immediate long-term health benefits for having stricter blood pressure treatment during the short length of a pregnancy in patients without cardiovascular disease risk factors. There is concern that lowering maternal blood pressure may actually compromise the uteroplacental circulation and negatively impact the fetus. And lastly, therapeutic options are quite limited due to concerns about adverse fetal effects. So after reviewing all the scientific information, there's still more research to be done. So there's been no major changes in that definition for hypertension in pregnancy. This slide here is just highlighting some of the multiple different organizations and societies that are out there and their differences in treatment thresholds, as well as when to treat with antihypertensive therapy. You can see ACOG's definitions, which is what we use here at Hillsboro Medical Center, up at the very top. This is a study done in 2021 in JAMA that I wanted to highlight that was looking specifically at investigating whether or not reclassifying hypertension with the 2017 ACC-AHA hypertension guidelines better identified women at risk for preeclampsia and adverse neonatal events when compared to current standard of practice. This was a retrospective cohort study that was done at Kaiser Southern California with a predominant Hispanic population. These results showed that the prevalence of hypertension with the ACC-AHA guidelines actually increased the definition of people with gestational hypertension by 17.8% and identified about 20.8% more patient at risk for preeclampsia and about 4% more neonates at risk for adverse neonatal events. This suggests that by using a lower blood pressure threshold, we can identify more people at risk. But again, given the conflicting evidence we discussed before, there's still more research to be done. This is a graph from the same article from JAMA that's just highlighting that if you look here on the left side of the graph, patients who were reclassified from gestational hypertension, which would be greater than 140/90, to chronic hypertension, which is greater than 130/80, based off the new criteria, they had the highest rate of preeclampsia compared to normotensive patients. So let's look a little deeper now into what some of the maternal and fetal outcomes are related to hypertensive disorders of pregnancy. This slide highlights that there are both short-term and long-term outcomes that can affect patients, particularly the mother. Dr. Saperstein had highlighted a lot of the short-term effects, and I wanted to focus today on some of the long-term effects that can happen. As you can see here, there's things such as chronic hypertension, type 2 diabetes, cardiovascular disease, coronary heart disease, heart failure, arrhythmias, stroke, vascular dementia, and chronic kidney disease, as well as venous thromboembolism that can be long-term effects related to having a hypertensive disorder in pregnancy. About 60% of all maternal deaths actually occur within the first year postpartum. And of the cardiovascular disease related mortality, peripartum cardiomyopathy is the leading cause of late postpartum death. I think the point I wanted to also make from this slide is that there is increasing evidence that having a history of preeclampsia should be considered in your cardiovascular disease risk stratification of your patients. So let's talk about the fetus. So after delivery, there are again both short-term and long-term complications that can happen related to having preeclampsia or a hypertensive disorder. On the left-hand side, you can see some of the main things I wanted to highlight is that preeclampsia is the leading cause of iatrogenic premature delivery, and most of this morbidity is related to being born prematurely, as well as that uteroplacental insufficiency. In the immediate postpartum period, things such as transient neutropenia and thrombocytopenia increases a neonate's risk for infections. And there's also increased risk related to the prematurity causing respiratory issues such as respiratory distress syndrome and bronchopulmonary dysplasia. There is an interesting prospective population-based cohort study done in JAMA Psychiatry in 2020 that actually also looked at specifically preeclampsia at term and whether it can have lasting effects on the neurodevelopmental development of children. And there is increasing evidence that there may be an association between preeclampsia at term and increased risk for ADHD, autism spectrum disorder, epilepsy, and intellectual disability. I think there's more research to also be done in this area. Next, I wanted to kind of focus on, now that we understand the complications a little bit better, how can we help prevent these things? So if you are seeing a patient in the preconception visit or during early pregnancy or the initial OB visit, things that you want to be focusing on is a healthy lifestyle and healthy weight, and screening primarily for cardiovascular risk factors. 90% of chronic hypertension patients have primary hypertension, but if they have secondary hypertension, patients actually have worse maternal and fetal outcomes. Baby aspirin is something that can definitely be recommended during the beginning part of pregnancy to help reduce your risk for developing preeclampsia. This graph here, or a table here, shows that if you have one major risk factor or at least two moderate risk factors, you should be starting low-dose baby aspirin around 12 to 16 weeks and continuing this through 36 weeks of pregnancy. And this can help reduce it by about 50%. So after a patient is discharged from the hospital, things that ACOG actually recommends specifically is to check a blood pressure within 3 days of hospital discharge, and again at 7 to 10 days or earlier if the patient is symptomatic. Strict return precautions are very important because quick treatment of severe range blood pressures is really important to prevent morbidity and mortality from cardiovascular disease. This slide here is just, again, highlighting that there's a lot of different recommendations depending on the societies that you're looking at regarding who should be seeing someone in the postpartum period. I think it just highlights that there is a diverse range of providers or clinicians that you can see for managing future cardiovascular risk. This slide is trying to focus on a new term that we've been starting to hear over the past couple of years called the fourth trimester. And this refers to the 12 weeks postpartum after giving birth. You can see here that there are multiple components of a postpartum care plan that are really important to a patient's health. And I want to emphasize this is a lot of material to have to cover in one, let alone 2 visits. Some things to consider when you are seeing a patient in the postpartum period are definitely related to mental health. As Dr. Saperstein mentioned, there is a very strong increase in certain mental health conditions that you want to be screening for, particularly depression and anxiety and post-traumatic stress disorder. Preterm birth in and of itself is associated with an increased risk for these things. Things to consider for breastfeeding is if a patient is on an antihypertensive, you want to make sure that this is safe for both the patient and the baby. And then for contraception considerations, you want to be avoiding estrogen-containing products due to the increased risk for exacerbating hypertension and thromboembolic events, as well as other cardiovascular events. Something that I learned when I was preparing for this speech is that there is actually a strong recommendation from ACOG, as well as our cardiology colleagues, to do a 3-month cardiovascular follow-up, primarily for this list of people, including hypertensive disorders of pregnancy patients. And really, this is just a way to emphasize the importance of screening patients who are at significant risk for developing cardiovascular disease in the future, making sure that they're getting close follow-up with their primary care doc. So during this 3-month cardiovascular patient follow-up, things that you want to be specifically doing is screening for smoking history, healthy lifestyle, if they have a family history of cardiovascular disease, checking their blood pressure and heart rate, assessing their weight, and then doing some lab work can be helpful, including checking a cholesterol panel, fasting glucose. If they had gestational diabetes in pregnancy, you'd want to be doing a glucose tolerance test, and then also checking for any urine protein. We know that screening for chronic hypertension, high cholesterol, diabetes, and obesity after pregnancy is especially helpful in preventing cardiovascular disease in these patients with hypertensive disorders. I am a family medicine physician, so I wanted to give some family medicine perspective. There is evidence that shows that adherence for patients attending postpartum care is actually quite low relative to follow-up visits for infants, or what we call well-child checks. And only about 40% of women actually attend their postpartum visit, compared to about 90% of mothers who or birthing parents who attend their well-child checks. And so there is a big, I think, gap in our current healthcare system in capturing interaction with our birthing parents to be able to address a lot of these cardiovascular disease risks. So here specifically at my clinic at South Hillsboro, we're doing a pilot program called Family-Centered Visits, which is combining back-to-back appointments with postpartum visits with the birthing parent, and offering it to be co-scheduled back-to-back with their well-child checks in order to increase attendance for those postpartum visits and be able to address all those comprehensive topics that were listed in the postpartum care team. This also can improve access to care by addressing social determinants of health. A lot of our health disparities are related to parents who aren't able to have proper childcare to be able to attend their visits, may not have transportation readily available to come in for visits. And so this is hoping to address that disparity and reduce those barriers. And then lastly, by having these appointments together, we're able to screen for a lot of mental health conditions, such as postpartum depression and anxiety, well past the 8 to 12 week postpartum visit. This is a nice little table showing you that the postpartum care team is going to consist of multiple people, both healthcare professionals as well as non-healthcare professionals. And it takes a village to be able to take care of someone in their postpartum period. So to wrap things up, just like the title of our talk, the heart matters. And so Casey's PCP actually happens to be a family doctor. And after she was managed by the midwifery team and OBGYN in the hospital, she decides to have her 8-week postpartum visit and her baby's 2-month blood child check with her primary care doc as a family-centered visit. She has lost some weight since exclusively breastfeeding, and her BMI has decreased from 34 pre-pregnancy down to 32 postpartum. She's really happy about that. Her blood pressure during her visit is 132/83, but she is otherwise asymptomatic. She has been trying to stay physically active and walks daily with her baby. But when you see her, she actually admits that she is feeling some mild postpartum depression symptoms, and her anxiety is getting the best of her as she tries to adjust to a newborn at home. You schedule her for a follow-up visit at 12 weeks postpartum, given her history of preeclampsia and elevated BMI, and plan to address her mental health concerns at that visit.
Thank you, Dr. Jackson, Dr. Saperstein, and Ms. Vinayuki for that excellent overview. We are monitoring the chat for some questions. And while we await questions from our audience, I did have a few questions that came in true to me. This is to each one of you, and you can take turns answering it. What types of gaps can our departments fill for each other? I find this such a unique panel of midwifery, OBGYN, and family medicine physicians coming together to have this important conversation. So where do each of you see opportunities to collaborate and complement your services?
I think Alicia Jackson really highlighted the way in which we can help coordinate care. Specifically, as obstetricians, we're seeing our patients both in pregnancy and the immediate postpartum period, but the effects of preeclampsia and hypertensive disorders of pregnancy go beyond that. And so highlighting that is something primary care providers, internists, everybody within the hospital should be aware of in treating the patient for their lifetime, really.
Thank you. I'm going to hand over to Ms. Yuki and then to Dr. Jackson.
And I think it's also important to create a full circle, so that way when you're developing that postpartum care plan, that patients can have that foresight and decide, who their primary care provider is going to be, before delivery, so that they can get on board and in the queue for the continuity of care.
I don't have much else to add. I think we here at Hillsboro Medical Center do a great job at collaborating with each other and making sure that we can support each other in whatever way possible. So as long as there's open communication between our teams, our departments, and our specialties, I think we all have the same goal in mind, which is to provide excellent patient care and continuity.
Yeah, no, I think our goal is to provide the right care to the right patient in the right setting, and we're so fortunate to have such breadth of talent to be able to do that. There's another question in the chat, which is actually a comment and a question. Comment is, love your family-centered visit program. What do you see as the largest barrier to educating women regarding cardiovascular risk related to gynecological history?
Thank you so much for that compliment. I'm really proud of this family-centered visit pilot program that we're doing. The largest barrier I feel is really people getting lost to follow-up. So like I mentioned before, about 40% of birthing parents don't even attend their postpartum visit, or they'll maybe attend 1 or 2. And that's really focused on the immediate postpartum. But these are cardiovascular disease risk factors are like for the rest of their life. And so you saw all the different components that are related to addressing contraception, postpartum both short-term, long-term complications, mental health. That's a lot of topics in a very short period of time. So I think it's hard for both the patient to fully grasp their head around, as well as for us as clinicians to make sure that we're giving adequate education and time to address all the different things that go into having given birth, miracle of life. So I think it's really making sure that we provide them the time with us to answer their questions and make sure that as things come up, as new symptoms might develop, we can help guide them through their health journey.
Yeah, I think you bring up a really good point, Dr. Jackson, because studies have shown that in general, women tend to prioritize the care of their family members and everybody else before their own, and there are significant barriers to them advocating and seeking care for themselves. And when they do seek care, there's often a tendency among providers to maybe somewhat not highlight the cardiovascular risks as much. And as you pointed out in your talk, and as data has shown, these are longitudinal risks with increased incidence of heart attacks and strokes and deaths, even as early as 5 to 7 years post-pregnancy. And as you can imagine, these are young women that just gave birth. So so important for us together to see what we can do to advocate and promote follow-up visits after childbirth. There was another question in the chat regarding what do you see as the largest barriers, particularly I'm thinking about the community that we serve in Hillsboro, one of the most diverse communities in the state of Oregon. And are there any unique aspects to how you deliver care at Hillsboro Medical Center that adapts to this cultural diversity of the population that we serve? I'll open it to all panelists.
I can start. Some things that I know that we try to do here at our family medicine clinic is obviously making sure that we're providing linguistically and culturally sensitive care. So there are interpreters that we have available, both video and the pandemic's kind of made in-person interpreters a little bit harder, but making sure that we have people available to speak a patient's language, because that is extremely crucial and important to making sure that we can communicate effectively with our patients.
I'll just mention, in addition to that, we highlight the fact that health literacy is very important, and speaking to a patient at their level of what their health literacy is. And preeclampsia for a medical professional is a complicated disease. And then for a layperson who has very little to medical background can be also very complicated, as we saw in our patient experience that Vinay talked about. There's a lot of this idea that anxiety or rushing or running can affect your blood pressure without the realization that there's a real underlying pathology. So we do, I think, a good job at Hillsboro of making sure we have those language barriers reduced by in-person interpreters and really trying to talk to the patient on their level.
I think another thing that we do really well is we listen and we provide a tailoring of care to the patient to meet the patient's needs of where the patient is at. We do offer a range of in-person appointments. We also offer virtual appointments and try to time things, appropriately, not to try to fit the patient into our schedule, but try to wrap our schedule around what works best for the patient. In terms of flexibility, appointments, if they need additional or extra time, providing them with the supplies, being available, for talk and chat through them on my chart as well. So I think, those types of services are really important for wraparound and for tailoring to individual needs.
Thank you all. I think those are all important considerations to provide inclusive care to meet the needs of all patients, both virtually, in person, through telehealth services, through interpreter services, through understanding the cultural needs and highlighting cultural competent care in a family-centered home model. I don't have any other further questions that I'm seeing in the chat come through. If you have any closing comments, we would welcome them at this time. Otherwise, I'm going to hand it back to you, Nick.
This was really incredible conversation. So I have to give you a direct thank you, Dr. Gupta, Dr. Saperstein, Dr. Jackson, and Vinay for leading us through today's discussion. And thank you everyone for joining this incredible learning opportunity. Considering last Friday was Wear Red Day for the American Heart Association, focusing on women's heart health, and International Women's Month is coming up in March, I believe this was a very timely conversation. I hope everyone has been able to take away a few points that are going to help you in your practice or in your daily life. And before closing out, because it's always good to have a little time back at lunchtime, I do want to make sure that everyone knows we have a follow-up survey, so you can let us know how we did and what we can continue to do so that we can keep you up to date on heart healthy information and resources. And with that said, and Dr. Gupta, no other questions coming through the Q&A, on behalf of the American Heart Association and Hillsboro Medical Center, we'd like to thank you for attending today. We hope you have a wonderful rest of your week and take care.